of cardiac events within 10 years are those with existing coronary disease. Yes, no, maybe, I don't know. Move on, next.
Higher risk.
Individuals at highest risk for a cardiac event. What's a cardiac event?
Heart attack.
A heart attack, exactly. We're going into heart failure. Within 10 years are those with existing coronary artery disease. True or false? Absolutely. Absolutely. You have coronary artery disease. Within 10 years, you are at highest risk of having a coronary event, meaning a cardiac infarction. Absolutely. So coronary artery disease is one of the highest indicators for having an MI. Okay. Coronary atherosclerosis is what we're starting with. It's the abnormal accumulation of deposits of fibrous and fatty tissue in the arterial walls or in the lumen. Okay, and those do down here. Okay, the fatty deposits are caused by several different things. It's not just one thing. It can start in as early as childhood. We are starting to see children that have high cholesterol, and that puts them at risk of coronary artery disease even earlier. That's kind of the philosophy behind our 30 and 40-year-olds who are having cardiac infarction. How is it possible that somebody in their 30s should have a heart attack? Well, the reason is that we're seeing more cholesterol, high cholesterol, the bad cholesterol, in younger and younger populations. I can tell you just most recently, my own young child, who's turning 13, had his annual physical, and he's gained quite a bit of weight this year because he's going through that growth spurt, but not all in the right direction. So his pediatrician asked me to do some lab work to just check where he's at, which will give us a baseline. So it is something that we can monitor through his lifespan and make sure that his cholesterol stays within normal limits. So they start now testing even young children. It is that significant. Development of the vascular endothelial injury over years can cause damage to the lumen of the blood vessel. Smoking, of course, is one of the biggest contributors, and the next biggest contributor is to coronary artery disease and atherosclerosis is what? Hypertension, the next biggest contributors. Okay? Macrophages, which are supposed to ingest lipids, become foam cells and actually transport the lipids to the arterial wall, secreting enzymes that actually further damage the arterial wall. So all of this is going on at the same time, which is adding these plaques to the arterial wall. These plaques are called atheromas that are produced in the vessels, which causes narrowing and obstruction. What these plaques do is the fat plaques actually go and attach to the vessel wall, and then fibrinogen and platelets and all sorts of other material that's within our vascular system starts to get hung up on these plaques, which causes these plaques to grow and grow and grow. And in so doing, narrows our vessels. Okay? When the plaque becomes unstable, it becomes a thrombus, and it can be shot into any part of the vascular or pulmonary system. Okay? And this is kind of what it would look like. This is a nice, healthy artery. You can see the endothelial cells which line the inside of the lumen. You can see the nice muscular layer, okay, and the outer layer of the vessel. The monocytes begin the migration, okay? Then you have the smooth muscles that starts to thicken, and you can see this, it becomes this fat layer in between, and all of a sudden, you've got this lipid ball inside the layer that has now become inside the vessel wall, not just on top of it, but inside the vessel wall, which you can see here, causes bulging outside into the vascular system, which is going to cause constriction of flow. Okay. Coronary artery disease obviously is within the coronary arteries that are feeding the heart muscle itself. And we have several coronary arteries. Okay, we have the right and left branch, okay, and the circumflex branch that goes literally around the heart. See, it goes this way. And that's the branch that's going to feed the back part of the heart, which is part of the area that is primo for myocardial infarction, which becomes the posterior of the left ventricle. This is the largest branch that goes all the way around. And it has all these feeder branches that go down into the ventricles. Depending on where the plaque, the atherosclerosis occurs, depends on what part of the heart has been starved of oxygen and what part is going to be damaged. Depending on the part of the heart that's damaged will depend on what the outcome is going to be. If the right side of the ventricle is damaged, you're going to see a little bit less impact as you wear the left ventricle, because the left ventricle does the most amount of pumping to the rest of the body, has the highest of the systemic pressures.
Would, but the SA node is on
It's on the right atrium.
the right.
Atrium, it's in the right atrium. And as you can see, the vasculature, most of it here, you can see the vessels are heading more south than they are north. So most of the vasculature is feeding the ventricles because the ventricles have the biggest amount of work. If you think about it, the atria, yes, they do contract, but most of their work is passive. Okay, they're much smaller and do much more passive work, while the ventricle have to go against resistance, pulmonary resistance, and vascular resistance. So they have the biggest muscle layers. It's the biggest part of the heart. The ventricles take up 2/3 of the heart. Okay, so most of the blood vessels, as you can see, the main arteries cover the ventricles. Okay, their pathways will go up. The collaterals will go up into the atria, but most of it's going south. So the damage to the heart is more in the ventricular area than the atrial area. Okay, clinical manifestations of coronary artery disease, symptoms due to myocardial ischemia. What does ischemia mean?
Lack of oxygen to your brain.
No. It's because of lack of oxygen. Yeah, it's because of lack of oxygen, but it's damage. It's damage to the tissues. It doesn't matter where in the body, but the word ischemia means damage to the tissue. Okay? Symptoms that and complications that are related to the location and the degree of vessel obstruction. So what very often happens in coronary artery disease is that somebody will have multiple vessels that are blocked at different percentages. And the one with the highest percentage is going to have the presenting symptom. All right? They will often have symptoms of angina pectoris, which we'll talk about in a whole little bit. Myocardial infarction would be the next worsening sign of coronary artery disease. Heart failure, and of course the worst sign of all, sudden death. That's usually not good. That's usually not recommended. Okay. With coronary artery disease, as we're going through these signs and symptoms, what are some of the risk factors for coronary artery disease? Genetic is a big one, absolutely. Genetics. What else?
What about age?
Age has, hold on a second. Age has less to do with it nowadays because, as I just finished saying, we're even testing cholesterol in children because we are finding that younger and younger populations are having heart attacks, and they're finding that they have atherosclerosis at a younger age. Age, yes, it has some impact, but not the way we used to think of it at all. What else was the next one?
Diet.
Diet, absolutely. Stress, for sure.
High blood pressure.
High blood pressure is a big one. Diabetes mellitus, peripheral vascular disease, abdominal aortic aneurysms. Okay, all of these are partly, and obviously elevated cholesterol. Which is the good cholesterol and which is the bad cholesterol?
LDL is the good one. HDL is the bad one.
Really? I'll find out. We'll find
Yeah, I
out.
agree with her. on that
Yeah,
one.
it is.
I agree with her on that one.
Is what? LDL is good and
No,
HDL is bad?
LDL is
No, she said
HDL is
HDL
bad. LDL
She
is
said
good.
HDL is bad.
LDL is bad.
No,
That's the bad?
Yeah.
Yes.
HDL is the bad.
No.
HDL is the
We're gonna find out when we get there. I don't know, that's his hang. This is too good to not let it hang. We're gonna find out as we get along. So one of the frequent symptoms of coronary artery disease is angina pectoris. Let me leave that till we get there. I have you.
Is it gender too? Gender?
Gender, yeah. It will be, in terms of risk factors, gender, males tend to have a higher risk until we catch up as females after menopause. Menopause just throws us over the edge for a lot of different things, coronary artery disease being one of them. Because the higher estrogen in our bodies helps to control our cholesterol. So, angina pectoris is associated with significant narrowing in any one or multiple narrowings in the coronary arteries. There are 5 different kinds of anginas. Okay. Stable angina, which is usually felt on exertion and goes away with rest. There's unstable angina, which increases in incidence and severity and is not relieved by rest or nitroglycerin, which is a vasodilator. Intractable, which is incapacitating pain, you can't get away from it. Variant, which is pain at rest due to a vasospasm. And then there's the silent angina, which the patient never had known that he's had an anginal event and is seen on an EKG. And that's kind of the scary one because you don't even know you've had a problem, right? Angina is usually experienced with physical exertion or stress. The myocardium is unable to provide for the oxygenation that the body is demanding, that the coronary vessels, because of their narrowing, cannot provide sufficient blood to that part of the heart. And that heart starts to have failure and starts to demand more oxygen and it's trying to tell you that something's not going on by creating pain, okay? Pain can be mild or severe, okay, very variable. It can be described as a tightness, a choking feeling, or a heavy sensation in the chest. Frequently, they talk about pain radiating up to the shoulder, up to the neck, okay, or to the back. Some people think that they're having epigastric pain, that they're having like heartburn, very often how it's described. And it can come and go. As I said, it can be variant, that it comes and goes. Some people, once it starts to worsen and they get really anxious that something's going on, also have shortness of breath, dizziness, diaphoresis. What's diaphoresis, everybody?
Sweating.
Sweating. And they may start to feel nauseous and vomit, okay? Those that have previously experienced angina and have their nitroglycerin, this is a good time to give it. Okay, rest and nitroglycerin are part of what we do. In unstable angina, as we said before, it's hallmarked by increasing severity and intensity and cannot be relieved by rest and nitroglycerin. And this is a very dangerous one because at this point you can easily slip into a full-blown myocardial infarction. So basically, angina is a precursor symptom that something's going on and you ought to be seeing the cardiologist and get tested. And definitely something that needs to be pay attention to. And nothing that should be ignored. Okay. Treatment for angina. Okay, obviously, if they've previously had angina and are being given nitroglycerin, they should take their nitroglycerin pills. And how do we take nitro?
1 to 2 times, something.
For 3 times, 1 every 5 minutes.
Yeah.
Okay, perfect. 1 every 5 minutes times 3. That's the maximum dose. And in the meantime, you ought to be getting your happy little body over to the emergency room. And this should be taken a look at. Okay. So that's the main medication. Once the patient is in the hospital setting, we're definitely going to put them on some oxygen. Okay, we're definitely going to make sure that they're monitored because we want to get a cardiac strip to see what's going on, see what kind of pattern we're getting. We're going to provide them with medications such as nitrates, which is like your nitroglycerin, but you could give other vasoactive agents. Because we want to, what are the vasoactive agents doing?
Opening
They're
up
dilating the vessel, so the other effect of a vasoactive agent is that it's going to change your blood pressure because it's going to do it not just to the heart, but it's going to do it to all the arteries. So So again, we're gonna be monitoring very carefully because the rebound experience can be hypotension from the vasoactive agents. Okay, we're gonna give our beta-adrenergic agents such as Lopressor, which will lower the heart rate and slow down the conduction across the myocardium. We're gonna give our calcium channel blockers like Norvasc, which also decreases the automaticity of the SA node and the AV node, and it slows the heart rate down. At this point, because the heart is no longer able to provide appropriate oxygenation, the first reaction is the heart, if it's not working stronger, it's gonna work harder by increasing its rate. Okay, so we wanna decrease the workload of the myocardium. And usually we are going to start them on some sort of antiplatelet and anticoagulant, because we know that if they've got atherosclerosis, they're at high risk for throwing a clot, and we want to prevent that. So we're going to, what's the number one thing that we give them? You see it advertised on TV. You think you have a heart attack, what do?
Beer, aspirin.
Bear aspirin, there you go. Bear gets the thumbs up from the universe. Give them a baby aspirin because it's an anticoagulant. Aspirin is a very good it's actually an antiplatelet aggregate. It stops platelets from aggregating, so that way they don't get onto whatever clot they've got going on, whatever atheroma is in their coronary artery, and it helps to prevent further activity. The other ones that would be given in a hospital setting is Plavix. And what's the new one on the market? Somebody help me out, I can't think of the word. We're giving it all over the place. It's a sub-Q. There's a new one on the market, I see it advertised, and I haven't seen it lately to come up with the word, it wasn't in my text. But there's a new anticoagulant on the market that's competing with Plavix. It's not coming to me.
It'll come eventually, but here's our list of medications.
Did I was strong, something like that?
You know what? It'll come to me at like 2 o'clock in the morning. It hasn't come to me yet.
She'll send everybody an email. I got it, guys.
I probably actually would. Okay, so beyond the drugs I just mentioned, the other kind of drug, of course, as an anticoagulant primer, first-line drug as an anticoagulant is heparin I. And at this point, it might actually be heparin IV versus sub-Q. Okay, so those are the basic ones that we give for angina. Okay. Wait a minute, did I miss one? No?
Where do you get those questions?
I'm not that creative. All right, so in our nursing care plan for our patients with angina pectoris, because part of our assessment would be, obviously, we would hopefully try to diagnose patients at risk first, those that are in the right age bracket, those that are eating a high-fat diet, those that are not following their lab work or have inappropriate lab work, those that are smoking, those that have a genetic history within their family of coronary artery disease, those that lead a very sedentary lifestyle. So we're going to start always with prevention. Once we've gone through that, we're going to do a physical history and physical. We're going to find out what the patient and the family's knowledge base is, and we're going to create a care plan to take care of our patient that is either at risk or is having active angina. Because we know that active angina means that they are at risk for a heart attack, better known as a myocardial infarction. Okay, so our diagnosis for these patients, we do not have a problem with airway exchange, so we can't use that one, although we love that one. Ineffective cardiac tissue perfusion. This is a nursing diagnosis that kind of covers a lot of the patients with cardiac disease of any kind. Anxiety of death, yeah, that would definitely be one, because anybody that's suffered their myocardial is worrying about that sudden insult. Knowledge deficit regarding their disease process and any medications they might be taking, and non-compliance and ineffective management of therapeutic regime, because usually it means lifestyle changes, and old dogs do not like to learn new tricks. Okay, so what are some of the lifestyle changes that somebody that's being diagnosed with coronary artery disease and/or angina. What kind of lifestyle changes might they? They might need to exercise, diet change, cessation of smoking, cessation of alcohol, okay? Could be change in their workload, decrease their stressors, things like that. Very difficult things. And medication. And taking of medication can very well be that these people, you know, have never had to be on a medication regime, and all of a sudden they're having to take not just one pill. Usually we're asking them to take several pills several times a day. And that's, for most people, that's a huge change. Just having to take medications on a daily basis. Associated problems would include acute pulmonary edema, because again, once the heart is no longer functioning, it will back up into the lungs, the fluid, heart failure, potential cardiogenic shock, certainly arrhythmias leading to cardiac arrest, and again, that the old myocardial infarction. So our plan would include goals which would be to preventative care, education, okay, preventative care, reducing anxiety, education about their disease process and medications and lifestyle changes, and helping our client figure out a self-care program that will keep them independent and in the most positive health possible. Okay. So our treatment for the patient with angina would include our nursing priority being tissue perfusion. So we're going to monitor them, we're going to put them on monitors, we're going to give them oxygen, and we're going to administer medication as ordered by the physician, or vasoactive. We're going to be prepared to give them those vasoactive medications. And pain medication, if it's required, if their angina is intractable, we may be giving them some pain medication to decrease their pain, which will also decrease their anxiety. What's the number one drug that's given? We're talking pain medication that's given in these situations.
Oh, morphine?
What did you say?
Morphine.
Morphine?
Yeah.
Is that a answer?
No, because it's hard.
Yes, absolutely. Absolutely.
Slow the heart rate?
No, it's not going to slow the heart rate, but what it's going to do is actually going to vasodilate and decrease anxiety and decrease pain. So morphine is the number one drug that is given. Absolutely. It decreases pain and decreases anxiety. And it's vasoactive. It'll relax the heart so it can dilate. Morphine, number one drug. Okay? Along with all the other drugs. But in terms of pain management and pain/anxiety, it is morphine. Okay, so to treat our anxiety, we're going to try to keep our client as calm as possible. We're going to use all our stress-reducing, try to do imagery while your heart is hurting. I don't know. We're going to teach our patient about what's going on, keep them knowledgeable about the tests that are being done and the medications that are being given, so that they can, again, work with their anxiety and help with their families, help their families understand what the process of their disease process, testing process, medication process, and long-term outcomes. A lot of patient teaching goes in, again, especially if it's the first time that this patient is having a cardiac insult. So lifestyle changes, as we just finished saying, lifestyle changes, disease process, medication, stress-reducing activities, which can be exercise and stress-reducing activities can actually go hand in hand. Take a walk in the park. It's very often kind of a 2-for-1, okay? And when to seek medical advice. Again, if they're being prescribed nitroglycerin, to make sure that they're taking it correctly, and to know that after 3 doses, you definitely need to be seen by a physician. Okay. So now we're doing all this teaching. How we're going to teach them to prevent myocardial infarction and angina. Diet and exercise. So we want them to have a low-fat diet. We're going to have them control their lab work. So we're going to have their LDL less than 100, their cholesterol less than 200, and their HDL less than 60. Triglycerides should be lower than 150, and there's a whole chart in your book somewhere in this chapter. And for healthy patients, for the normal healthy person, about how often should you have your lipid panel done? On a normal healthy person, it might be a little worse than
Every 6 months? Every couple of years.
Every 5 years in a normal healthy person, you should have your lipid panel done. That's the standard practice by the American Heart Association. And the answer to the question is the LDL is the bad cholesterol and the HDL is the good cholesterol. We'll get into that when we talk about that shortly. So MI, better known as myocardial infarction. What's happening in a myocardial infarction? We've gone from angina to the next level up. What's happening? So you all should have had that high protein, low carbohydrate diet.
Not enough oxygen to the
Okay,
heart.
not enough oxygen to a part of the heart because we've
the
had
blockage.
some sort of blockage, a vasoconstrictive event, okay, in the heart now. That heart, part of that heart muscle is actually necrosing and dying. Once it has died, it will forevermore will not regenerate, and we have now got scar tissue on the heart. So a piece of the heart will never work the way before. Once you've had an MI, your heart is never the way it was before because now you have caused death to a part of the heart. Okay? So it's permanent destruction of a part of the heart, usually caused by reduced blood flow of a coronary or a rupture of a coronary. Usually it's due to an atherosclerotic plaque and subsequent occlusion, okay, which becomes a thrombus. Okay. In unstable angina, the plaque actually might rupture the vessel totally, which is very, very bad. Okay. And this, on an EKG, you would see different changes in the EKG waves because, like here, it's telling you right here on this lovely little picture, that the posterior, the apex, down by the apex of the heart, we have seen a change in the zone of injury, and you actually go from having a peaked QRS wave to a depressed Q wave. It's a very common sight, what's seen on the EKG. You guys see the difference? Okay, so what are the symptoms of an MI? Chest pain, absolutely. Absolutely. Is it always just chest pain? Like, oh my gosh.
Shortness of
Okay.
breath.
Confusion.
Excuse me?
Confused.
Shortness
Yeah,
of breath.
okay. I'll go for confusion. Why am I missing a page? I'm actually missing the whole page here. Oh, that's okay. 2 minutes. Do this. I'm sorry, what did you say, Sharon? Nausea, anxiety. A lot of people will say they're having indigestion. Absolutely.
How do you really tell the difference? Like, what do you tell someone? Just EKG, that's the only thing.
That is the number one way to tell. You put them on an EKG, and you see EKG changes, and you do lab work. And you actually can see on lab work, which we'll talk about in a second, changes in their cardiac enzymes. Yes. Okay, but the person who's having indigestion, okay, who has never suffered indigestion in the room? Okay, no, good. Everybody's had a little bit of reflux, indigestion, pain. If I put you on a cardiac monitor, am I going to see cardiac changes? If I take your pulse, am I going to see a change in your pulse if you've had if you're suffering some indigestion?
At the time, like right then and there? Wouldn't the pain make you like
The pain of indigestion and the pain of a heart attack is not at the same intensity level. People will interpret it because of the location, because remember, the heart is right below the sternum, and particularly if your infarct is down low by the apex, you're in the same physiologic area. But the intensity that people experience is a little bit different, even though they'll talk about it as epigastric pain, as heartburn. When you put them on the monitor, you're going to see, and you're going to see a pulse change. They're going to be tachycardic. You're going to see pulse changes. You're going to see that their blood pressure has bottomed out. You're going to see changes, physiologic changes in their vital signs. You're not going to see the same if you're having indigestion. Now, you're just going to have discomfort. Okay? So you're going to have a lot of the same symptoms as you do with angina, but it's unrelievable. Unrelievable. You can progress easily from an angina that's protracting over several hours, even days, okay? And then kick it right into a myocardial infarction. It's not uncommon, okay? but usually they'll talk about that radiating pain to the left shoulder, up to the jawline, to the back. Some people will talk about it as stabbing pain because it literally goes right through them. But it depends on what coronary artery has been blocked, how many of the arterioles have been blocked, to what degree, and how much damage has been done to see the intensity of the heart attack. It can be very mild, or it can be quite major, depending on how much blockage you have. And most people that have atherosclerosis disease or coronary artery disease don't have just one blocked vessel. Usually they'll have multiple vessels, as I said before, at different degrees, but it's the one big one. You know, whoever has the 90% blockage, that's the part of the heart that's gonna die. I know my own dad, he had 3 out of 5 vessels blocked the first time he had a heart attack, and they were like 30, 50, and 90%. And it was the 90 that got him. And that's nothing that's not uncommon. It's usually, it's not just one vessel, all right? Chest pain is the #1 indicator. The next one is going to be the EKG, changes in your EKG, changes in your blood pressure. Okay. There are 2 different kinds of MIs. One's called the ST elevation MI, and that's where you're actually going to see changes in the EKG, your ST wave changes, and that's due to the damage to the myocardium. And then you have the non-ST elevated MI, where you don't get the definitive changes, but you have cardiac enzyme changes, and that's how you know that the person has had an MI. And it has to do with which part of the cardiac of the heart has been damaged. Okay, so to refresh, chest pain, shortness of breath, indigestion, nausea, anxiety, cool, pale skin are going to be your main symptoms. So that patient's going to come into to the emergency setting. They're going to be put on a monitor immediately. Anybody that's suspicious of an MI, of course, is going straight onto a monitor. We're going to do a patient history on them to see what's been going on. 12-lead EKG will be done, and they should see T-wave inversions and changes in the ST segment, usually elevations, with an abnormal Q wave. Okay. Lab tests that will be done is they're going to look at the creatine kinase bioenzymes, and what happens is that these enzymes are released when there's cardiac cellular damage, and they go into the bloodstream pretty quickly. So an elevation in these enzymes will give them an idea of the fact that you've had a cardiac insult, and how high they are will give them an idea of how long the insult has been going on. Okay, those are normal enzymes. They'll do a myoglobin, which increases 1 to 3 hours after a cardiac insult, and will peak in 12 hours. So again, this will give them an indicator of how long ago did you have this cardiac event. Okay. The other one is they're doing is a cardiac protein called troponin, which increases within hours after cardiac insult and doesn't drop off for as long as a week. So again, it gives them an idea of the length of your event. Okay, these are some of the different check 1 and 1 and 2, different labs that are going to be done. Now, as soon as your patient gets in, what's the first thing you're going to do? Put them on oxygen and an EKG machine, absolutely. We want to provide oxygen to that heart muscle so that we don't get further damage, so that the rest of the coronary arteries are able to provide as much oxygen to the remaining part of the heart. So oxygen is definitely one of the first things you do. Slap them on a monitor, you put oxygen on them. Again, these are the patients that get that baby aspirin right away. We're going to do a lot of the same treatment as we do with our angina patient. Going to give them microbicin. Again, that morphine to vasodilate, relieve the pain, and decrease the anxiety. Okay? They're going to give you your beta blockers. Okay? Then they're going to start giving some other medications within the first 24 hours. Your angiotensin converting agents. And at this point, they're going to do they might want to do thrombolytic therapy, which is giving those clot busters. But that would be after they've actually done some sort of either angiography or cardiac cath to see which vessels are blocked at what level, what amount. They will start IV heparin, unless they want to do that angiogram, because they can't do the heparin if they're anticoagulated. And bed rest. And there's not much beyond that. The invasive coronary procedures that they're going to do are usually, if they can do, if they want to do that thrombolytic therapy, is usually done within 60 minutes of hitting the ER because it has the most amount of effect. That would be done under radiology, invasive radiology, which is now definitely an up-and-coming field where they're doing a lot of therapies a lot earlier. Okay? The bottom line is that our goal is to reduce myocardial cell death. Okay, that's the biggest goal, because the more cell death there is, the more scarring we're going to have on the heart. So we want to reduce that. Okay? So again, vital nursing care, assess all symptoms carefully, monitor the EKG, okay, and get them on oxygen to decrease that myocardial death. Some of the nursing diagnoses that you're going to have along with this is going to look exactly the same as your clients that have had an anginal event, which is ineffective cardiac perfusion, risk of fluid imbalance, ineffective peripheral tissue perfusion that has to do with your cardiac perfusion, death anxiety, of course, and deficiency of knowledge. Okay, complications that go along with myocardial infarction include pulmonary edema. If the heart muscle is not working well, you're going to have backflow into the lungs. Heart failure, again, same reason. Cardiogenic shock, dysrhythmias, and pericardial effusion and tamponade, which will occur because the heart's not perfusing. Your nursing goals will obviously be to have increased tissue perfusion to the heart and to the periphery, to decrease pain, decrease the incidence of damage to the heart, provide education so that your patient will lower their anxiety level as well as their family members, and eventually teach them how to adhere to a self-care regime that allows them to maintain the most positive health possible. So it would be education about their disease process, their risk factors for this disease process, the medications that they will have to take, and what kind of lifestyle changes that they're going to have to do if they wish to stay healthy. Some of the procedures that they will do to alleviate some of these issues is the percutaneous coronary intervention, which is basically your cardiac cath, where they go through the femoral, as they show you here, with a catheter that has pressure sensors as well as cameras, and they also have balloons in them. And what they will do is they'll pass it through to an area that has the plaque, the atheroma. And I call it roto-rooter work. They actually inflate the balloon, the objective being to break up this clot, okay, to break up this clot so that it can be reabsorbed and open up that coronary vessel. Now that improves the flow through the vessel so that the rest of the heart that vessel is beating is well perfused, but it does not change the cellular death that has already occurred. At the same time, they can also put in a stent, which looks basically like a little tiny straw, but again, helps to hold that area open. And also it's usually has a material on it that doesn't allow more clot to form, which then reduces the risk of having that area become having the plaque put back on it physiologically. Okay. The other is a much more rapid procedure where they will do coronary artery bypass, that are known as a CABG procedure, coronary artery bypass, which is basically rerouting of the vasculature. They'll use the saphenous vein, and they'll actually take the saphenous vein out of the leg, the lower leg, and they'll use segments of it to kind of basically detour the blood flow. So as they're having vessels down here that are not working very well, that are clotted up, they will go from either the aorta or one of the left subclavian artery. Usually it's the left subclavian because obviously the right is too far away. They'll use the left subclavian artery and they'll actually graft between the left subclavian and the coronary. So now the blood flow, the oxygenated blood that's going from the aorta through the subclavian is now being rerouted back down to the heart, okay? So it's bypassing whatever clotting is going on. That's you can have a single bypass, double bypass, triple bypass. We've all heard this language. Well, if you have a triple bypass, what's literally going on is that this is divided up in 3 and it's going to 3 of your 5 coronary arteries. So that's a pretty extensive procedure. Remember, that's a really extensive procedure in that it requires an open chest. It's not an open heart, but it's an open chest where they actually crack the sternum. It takes a year to recover from that, for the sternum to recover its solidity. So it's a serious procedure that it's not something that they do unless they absolutely have to. Renee?
Yeah, my dad had that, and he just went for a stress test, and we just thought everything was okay, and then they told him, he was gonna be admitted. I just didn't realize how extensive the procedure is.
It's a very extensive
Yeah.
procedure.
It was just like, very odd, you know, because he never went to the doctor or anything, and that was like his first major procedure.
Well, he was actually then very lucky because he obviously did not have symptoms of the compromise, so it was caught before he had a chance to have cellular death.
When he was doing his stress test is when they found it.
That's why you shouldn't drink so much coffee.
Really?
What's the difference between the open chest and the open heart?
Open heart is you're cutting into the heart itself. Okay, once you have to cut into the heart itself, I'm not thinking off the top of my head, but I can't think of a situation where you don't have to go on cardiac bypass machine. So it's a much more invasive surgery than when you have to actually cut into the heart and do an open heart surgery. This is not open heart, but it's open chest. An open heart is an open chest, that's taken at level 1, raising it right up to level 2.
Is it always the same vein from the keyhole?
It's the saphenous vein. It's
It's
usually the one that they
always-
use. It's the number one they use because it's the biggest of the veins in your leg, and you have a lot of collateral circulation, so it doesn't harm the circulation return to your heart. So it's what they use that is the most efficient, and it's a nice long vein. So usually that's the one that they use is the saphenous, the great saphenous. And it's diameter-wise, it's big enough to support the blood flow.
And it's all the way down to the leg?
The saphenous, yes.
Right.
They take it out. They don't leave it there. They take it out. They cut it. They don't need it touched.
So you don't need it in your leg? Once they take
You
it
can
out?
live without it because you have enough collateral circulation of other veins that will support the blood flow in your leg.
Okay.
You need it in your heart. If they're doing this, you need it in your heart more than you need it in the leg.
Right.
Yeah. Because you have
And
other
it goes on the
vessels.
left.
The left's favorite. Okay, so now we're going to talk about infectious inflammatory cardiac disorders. Okay, which really are talking about our valvular disorders, things that affect our valves. Okay? This is just some terminology that we're going to run through. Regurgitation is a valve that does not close properly, so you have backflow of blood into the previous chamber. So if we were talking about our AV valve, that would be that we would have backflow from our ventricles back up into our atria, which is the most common. Stenosis is where the valve does not open completely and blood through the valve is reduced because now we have a narrowing. Stenosis means a narrowing of any kind. And then you have valvular prolapse, where the valve, and this happens in the AV valves, the leaflets actually stretch into the atrium during diastole, which again prevents full flow of blood into the ventricles. These are the 5 different, 5 different kinds of valvular disorders that are most commonly seen. And kind of tells you which valve is involved, which makes it kind of easy. Okay? We're just going to go right into mitral valve prolapse. We're talking about here already. Okay. Here we go. Mitral valve prolapse is the most frequently seen in females. Us ladies have the advantage on this one. And basically what's happening is that the leaflets of the mitral valve, which is which one again? Which valve is the mitral valve? Where does it go?
It's on the left side.
On the left side of what? My ear?
Heart.
Okay, left side of the heart goes from where to where? Geraldine's like, I wish I kept my mouth shut. The left atria to the left ventricle. It's an AV valve, okay? So what happens is the valve is, in mitral valve prolapse, is the mitral valve, basically it's kind of sinking into the ventricle. So we're not allowing for full blood flow into the ventricle. Most people, most ladies who have that don't even know it. They don't even have symptoms of it, okay? If there are symptoms, they're gonna have fatigue, shortness of breath, maybe some palpitations and chest pain, and obviously with all of that, we get anxiety. And the reason is because we're not getting enough of our oxygenated blood from our left atria to the left ventricle, so that is then being ejected into the body, so our peripheral tissues don't have good perfusion, therefore we're feeling that fatigue. The shortness of breath can occur because we're getting a little too much flow in our left atria, which once the left atria has stretched to its maximum, it's gonna backflow into our lungs. Okay, if it backflows into our lungs, we're gonna feel that shortness of breath, okay? On auscultation, we're gonna hear a little bit of a click. That's pretty much it. And it's usually diagnosed, testing-wise, with an echocardiogram, okay? They might do a cardiac ultrasound as well. There's not much we're gonna do for it right now. Mitral regurgitation is almost the same thing because it's still with the same valve, but what's happening is that the valve itself is not closing well enough. So we are having some blood flow when the ventricle contracts. We're getting some blood flow back up into the atria. So once again, we're gonna have a problem that the atria's got too much blood in it. So it will eventually back up into the lungs. Okay? Usually that happens because the chordae, which are those like little strings that attach the valve to the bottom of the ventricle, have become fibrosed and they become kind of stiff so that they don't close properly, and it's allowing, during a ventricular contraction, it's allowing the leaflet to stay a little bit open. Okay? It's seen mostly in patients who've had rheumatic fever that causes rheumatic heart disease, and infective endocarditis, and in people who have collagen disease, such as lupus. Okay? The biggest complication of this is heart failure because of the backup of blood into the atria that eventually will back up into the lungs. And on auscultation, we'd hear a high-pitched blowing sound, and it's usually diagnosed with an echo, cardiac echo, and sometimes they'll do a transesophageal echocardiogram, which they actually put a Doppler down into the throat and they actually can see what the heart is doing. To relieve the symptoms, we're going to use our beta blockers and our angiotensin receptors. If it doesn't work medically, the next step is surgically, and they'll do what they call a valvuloplasty, which we'll be showing you in a few minutes. Our third kind of valvular disorder is mitral stenosis. So what's this? I've given you regurgitation, I've given you prolapse. So what's going on in stenosis? There's a narrowing, right. What are you saying, Vicki?
No, it's
Tightening or a narrowing of the mitral valve. Okay, so if it's tightening, what's going on hemodynamically?
Blood's not
Okay.
going through.
What's not getting enough blood? Okay. We're in the heart, so yep, it's the heart. So let's get a little more technical. Okay, we've got atria, we got a stenosed mitral valve, we got ventricle. So if there's a stenosis in the valve, what's happening hemodynamically? Let's think about it. Where's the blood going? Where's it not going?
It's not going into the ventricle.
It's not entering the ventricle because of the narrowing. We got congestion, we got traffic jam at the so where's the blood going? Because this heart's gonna beat no matter what.
It's staying in
It's-
the atrium.
It's staying in the atrium. The atrium's stretching, so it is
Backing up.
backing up where?
The AV, the mitral.
In the lungs. In the lungs. Okay. Again, remember yesterday we did follow that drop of blood? There was a reason I did that. So if you think of how dynamically the blood is supposed to flow, when you look at some of these valvular disorders,
you can figure out, well, if it's not going in one direction, there's only one other direction it can go, which is usually backing up. So if it's going to back up into the lungs, what kind of symptoms are we going to see in this patient? Shortness of breath, because now we got overflow of blood that is now in the lungs, which is impeding oxygen exchange. So we're definitely going to have shortness of breath. What else are we going to see?
Blood.
Crackles.
They're gonna throw up blood?
They're not throwing up blood, but that's a really good one, because the blood is not going into the bronchi, it's staying in the vasculature. So we're not going to see that symptom. Okay? We're going to changes in blood pressure. We're going to actually increase our pulmonary pressure because we got backflow of blood into the pulmonary system where it doesn't belong. Okay? What's happening from the ventricle forward? What's not getting enough blood?
Our extremities, the body.
Peripherally, absolutely. Okay, peripherally. So we're going to see that our patient's going to have dyspnea, which is difficult breathing, more than shortness of breath, fatigue, because they're not getting enough peripheral circulation to the tissues. They will have a cough, they're going to wheeze. They will have orthopnea, which is difficult breathing when lying down. Okay.
Cyanosis, they don't get cyanosis.
They will become cyanotic, and they will be at risk for respiratory infection because they have congestion, blood congestion in their lungs. Okay, upon auscultation, they'll have a low rumbling diastolic murmur low down in the apex of the heart. Okay, again, use the same diagnostics: echo, cardiac Doppler, and for this one, they might actually do a cardiac cath, and they actually can see the stricture. They're going to be going into heart failure, so we're going to use the treatments of heart failure, which we'll be discussing shortly.
In the lungs, will we hear,
You may hear
in the lower
wetness.
lobes or in the?
Yeah, you're going to hear them, but you may hear wet sounds in the lower lungs from the hyperperfusion. Okay, aortic regurgitation. Where am I? What's going on? Spitting out or spitting in?
Well, when we regurgitate, it's hard to get it out, like throwing up.
Okay, so
Would
so
it
what do
be
you-
backing up?
Well, isn't backing up reflux?
reflex is backing up, but hemodynamically, what's going on in aortic regurgitation?
Like the blood, are we
There's
worried that the blood will be going
leaking out.
backward?
The blood is going backwards from where to where?
From the aorta
To?
To the left ventricle.
to the
The aorta's
ventricle?
not connected to the lung.
To the ventricle?
To the left ventricle. You have regurgitation, so what's happening is that your aortic valve is not closing completely, it's staying a little bit open. So some of the forward flow, the ventricle has now pushed into the aorta a little bit, spits right back, or gets regurgitated back into the ventricle. So now what's gonna happen in that ventricle?
It's gonna overflow.
It's going to overflow. So so now I'm overflowing. What's the ventricle going to do to compensate for the extra flow? It's got two things it can do. What did you say, Vicki? Okay, well, it will pump harder to compensate for sure. So when your muscle pumps more and more and more, what happens to that muscle?
You get weak.
Sometimes it'll get weak, but there's another action that happens. And any bodybuilder will tell you all about it.
It's cramping.
It gets bigger. That's why they pump a whole lot more, heavier and heavier and heavier. That's called hypertrophy, cardioventricular hypertrophy. The actual muscle layer of the heart thickens. Okay, that's not necessarily a good thing, because if it's thickening, what's happening to the ventricular chamber? It's getting smaller, so it can accommodate less and less blood. So you get ventricular hypertrophy. Okay. And eventually what will happen with that hypertrophy is actually will cause the ventricle to stiffen. And if it's stiffening, it cannot contract as well, so you lose contractility. Okay. So this is a patient that will also be short of breath, fatigue, because we're not ejecting as much blood into the peripheral vascular system. And eventually, if it gets bad enough, it will eventually backflow all the way into the lungs. They will also have a murmur in the fourth intercostal space. Biggest signs is a widening of your pulse pressure, and it's also diagnosed in the same way. Cardiac echo, EKG, okay? And they will do the same treatments for this, which is rest, vasodilators, and calcium channel blockers, and eventually, if it's bad enough that they're causing heart failure, which would be the end product, they will do a valvular replacement or valvular surgery to improve the status of the valve. Valvuloplasty or valvular replacement. My dad just had that done. I have to tell you, it was kind of a wicked interesting experience because he was wicked bad heart failure, and he had aortic insufficiency. His aortic valve went, his standard, which he lives with, is aortic valve that functions at 40%. And he totters around quite well with 40%, it has for a year. It dropped down to 18%. Yeah. So he was, he and St. Peter were having lengthy conversations, negotiations, as I told him. My dad is a grand negotiator, businessman. So I'm like, you're having some negotiations with Peter, but Peter hasn't met your terms yet. He's like, nope, not yet. So even though he was not a great candidate, it was kind of in for the penny, go for the pound, or you're going to definitely finish this negotiation with Peter. And they decided to do a valvular replacement, and they actually do it, believe it or not, under catheterization for cardiac cath. It's not even necessarily a surgical procedure. And they actually, I have no clue how, so don't even ask me, but they actually use a mechanical valve and they put it in. And I think they ablate the valve that's there and put in a new one. And it brought his valvular function back up to 40%. It was kind of an amazing change. And at that point, he was in almost total renal failure on dialysis. So it was kind of cool. Kind of cool that it actually worked. I'm like, oh, I'm going to be teaching all this. This is really cool. I can use it as a teaching tool. So it's really cool. And aortic stenosis is going to be very much like mitral stenosis, except it's in the aortic valve, which is obviously a very serious problem when you have aortic stenosis because you're not getting forward flow. Your aorta is staying very narrowed, the valve is staying very narrow, so you're getting very little cardiac output. Not a good situation, and it's usually due to degenerative changes and calcifications with age. This is my dad, 100%. And it happens over years and years, okay? And basically it's going to be the same symptoms because your heart's just basically going to fail. You're going to have the same basic treatments, but these are the patients that are going to need replacement. Because once it's stenosed, there's not a whole lot they can do for it, and they'll do what you call a valvular replacement, which is a valvuloplasty. There are several different versions of it. The commiserotomy is where they actually cut the pieces of it to try to open it up. The balloon valvuloplasty, which is actually where they use the same kind of, like I talked about before, for atherosclerosis, where they use a balloon to pop it open. What they do is they use the same thing. They use a cardiac cath mechanism. They go in with a balloon and they put it through the valve and they open the balloon and they literally rip it right through, trying to open up that valve. At that point, hopefully they're trying to get rid of some of the calcifications by popping them off the valve. And then they're just leaflet repair surgery, and if the chordae are too stiff in the AV valves, okay, if they have as I said before, you can have fibrosis of the chordae, which is not allowing the chordae to loosen up and allowing those valves to close during a contraction. They will go in and cut some of the chordae to allow those valves to close so you can get the appropriate closure. So these are just some of the ways they do what's called valvuloplasty, which is surgery on the valves. If none of this can work, then they do valvular replacement.
If they cut the chordae, does it stay open then?
Well, the chordae what the chordae are doing is it opens them up. So we want the chordae to then bounce back and close. So what they'll do is, most of the time, from what I understand, is not they're cutting them all. They're just cutting enough to allow for closure, or they're going to scrape them down because some of the reason that the chordae don't close is that they've become fibrosed. So they try to get rid of some of the material to allow them to close. Okay, and here, it's also in your book, it shows you how they do a valvuloplasty. Here, you can see they actually have dilated a balloon and they basically rip it right through, trying to take care of the fibrotic material. And there are just different kinds of annuloplasties where they go around and try to shrink those that have been, gone too big around the annula, which is the